Pediatric Acne and Rosacea by Brianka Larkin. Classification of acne in pediatrics. Prepubertal acne has been classified into the following age groups: neonatal acne, 0 to 6 weeks, infantile acne, 6 weeks to 1 year, mid-childhood acne, age 1 through 6, and pre-adolescent acne, age 7 through 12. Neonatal acne is estimated to affect 20% of newborns. Neonatal acne takes the form of comedones that extends from the scalp, upper chest, back, and inflammatory lesions on the cheeks, skin, chin, and forehead. Neonatal acne does not usually result in scarring. Infantile acne is rare. It occurs in infants up to 16 months of age and presents as comedones, papules, pustules, and occasional nodules. It predominantly affects the cheeks. Occasionally, it leaves scarring. Mid-childhood acne is very rare. At this age, an endocrinologist should be consulted to exclude possible hyperandrogenism. Pre-adolescent acne can be the first sign of puberty, and it is common to find acne in this age group. It often presents as comedones in the T-zone, the region of the face covering the central forehead and the central part of the face, the brows, the nose, and the lips. Causes of prepubertal acne. Neonatal acne is thought to be a result of hyperactive sebaceous glands responding to neonatal androgens and maternal androgens that have crossed through the placenta. Androgens levels decrease after approximately 1 year. Then around age 7, androgen production restarts due to the start of puberty. From birth to around 12 months of age, luteinizing hormone levels are similar to those during puberty. In males, this results in increased testosterone production and may explain the higher incidence of acne in boys of this age compared to girls. Sebum production leads to increased colonization of the hair follicles by the acne bacteria. As in adult acne, this results in follicular obstruction by sebum and keratin debris and lead to inflammation. Other causes include gonadal or adrenal tumors, Cushing's syndrome, congenital adrenal hyperplasia, and precocious puberty. Diagnosing prepubertal acne. A clinical history and physical examination should be done. This may detect accelerated growth, early sexual development, and signs of hyperandrogenism, such as hirsutism. If accelerated growth is suspected, a bone age x-ray of the hand and wrist should be considered. Majority of children with acne will not require further investigations. If the findings on a clinical history and examination in children aged 1 to 6 years old indicate that further investigation is required, or if the acne is severe or unresponsive to treatment, an endocrinology referral may be required. The levels of the following hormones should be measured: free and total testosterone, follicle-stimulating hormone, prolactin, hydroxyprogesterone, luteinizing hormone. Treatment of prepubertal acne. Treatment for prepubertal acne is generally the same as adults, with the exception of restrictions by age. From age 1 to 7, the primary objective is to rule out underlying systemic abnormalities. Oral tetracyclines is not used in age 8 and under due to damage to tooth enamel and developing bones. The treatment for children with moderate acne is 250 to 500 milligrams of the oral antibiotic erythromycin in single or split dosing. Erythromycin is best used in combination with a topical regimen such as benzoyl peroxide and or a topical retinoid to reduce Cane's resistance. Acne vulgaris, often referred to as acne, is a disorder of the pilosebaceous follicle. This condition occurs when hair follicles plug with oil and dead skin cells. It affects 90% of adolescents. Typically presents at age 8 through 12, presents at age 15 through 18, and resolves by age 25. Classification of acne vulgaris. Comedonal is open and closed comedones. inflammatory papules and pustules, cystics, nodules and cysts. Also, severity and presence of scarring needs to be described. Post-inflammatory hyperpigmentation may also develop. Pathogenesis of acne vulgaris. Morphology. Acne begins with clogged pores. The formation of acne lesions occurs when hair follicles are blocked with dead skin cells, bacteria, and oil. Open comedones are blackheads and closed comedones are whiteheads. Blackheads, plugged pores with a black top. Whiteheads are plugged pores with a white top. Acne vulgaris. Triggers of acne besides hormone include wearing tight-fitting clothing and headgear like hats and sports helmets, air pollution in certain weather conditions, especially high humidity, using oily or greasy personal care products like heavy lotions, creams, or working in an area where you routinely come in contact with grease, such as working at a restaurant with frying oil. Diagnosing acne vulgaris. A history and physical exam should be done. During this exam, the provider will closely look at the skin and ask in-depth questions to learn more about the patient's symptoms. In addition, they may also ask about risk factors for acne such as stress level, family history of acne. Diagnosing acne vulgaris. Grade 1, mild. Grade 2, moderate or pustular acne. Grade 3, moderate, severe, or nodule-cystic acne. Grade 4, severe nodule-cystic acne. Treatment of acne vulgaris. Treatment varies depending on your age, the type of acne you have, and the severity. The goal of acne treatment is to stop new pimples from forming and to heal the existing blemishes on your skin. Topical acne medications, benzoyl peroxide as a leave-on gel or wash. It targets surface bacteria, which often aggravates acne. Lower concentrations and wash formulations are less irritating to your skin. Acne vulgaris patient teaching. Adverse reactions of topical retinoids include dryness, pruritus, erythema, and photosensitivity. Use sunscreen and protective clothing. Do not use with benzoyl. And pay close attention to pregnancy category C. Topical antibiotics often irritating and can cause dry skin, so use a moisturizer. Washing your hands at least once daily with warm water and a gentle cleanser. Washing your skin after you exercise or sweat. Avoid using skincare products with alcohol, astringents, toners, and exfoliants, which can irritate your skin. Removing your makeup at the end of the day or before you go to bed. Choosing an oil-free moisturizer to apply on your skin after cleansing. Avoid popping, picking, or squeezing your acne. Pediatric rosacea is an ongoing skin condition that causes redness, pimples, broken blood vessels, and a misshapen nose. It most often affects the face and the eyes. In some cases, it can also affect the neck, chest, or other areas of the skin. Rosacea is very uncommon in children. Classification of peds rosacea. Erythematous rosacea is characterized by persistent redness on the face. Small blood vessels beneath the skin surface may become enlarged and visible. These symptoms often flare up and then disappear without treatment. The redness can get more persistent, cover more skin, and even become permanent. Pediatric rosacea. Symptoms of rosacea in children are similar to those in adults. They primarily affect the face and the eyes. Red or irritated eyes, styes or pink eye, red swollen eyelids that may itch and can look greasy or crusty, long-lasting flushing on the face, burning or stinging face, facial swelling or edema, dry and rough skin. If left untreated, rosacea can worsen in children. Diagnosing and treating pediatric rosacea. To diagnose pediatric rosacea, take a complete medical history of the child, including family history, conducting a thorough physical examination of the child's skin and eyes, reviewing any medication the child may be on, checking for acne. Patient teaching for pediatric rosacea include using only fragrance-free products, wearing broad-spectrum, water-resistant 30 SPF or higher sunscreen containing titanium or zinc oxide every day, avoiding product that contains methanol, camphor, sodium lauryl sulfate. Avoid using rough skincare tools on the skin such as loofahs, sponges, brushes. Medication will improve symptoms but will not reverse underlying redness and flushing.